Welcome to the deep dive. Today we're tackling a topic that might seem straightforward: ulcers. But trust me, there's a lot more beneath the surface than you might think.
That's right. We often just think of a cut or maybe a sore that won't heal, but an ulcer is, well, a very specific kind of break in the body's protective coverings. Understanding them gives us a fascinating look into how our tissues respond to damage.
Okay, let's unpack this a bit. We're working from material by Dr. Sunil Kumar, and he defines an ulcer fundamentally as a disruption, a break in the continuous layer of cells covering our skin or mucous membranes.
Yeah, think of it like a pothole on a road. It's a gap where the surface has literally broken down.
Right, due to what Dr. Kumar calls molecular death of the cells right there in that spot.
Precisely. And what's truly interesting is that this basic definition covers a huge variety of appearances and, importantly, underlying causes.
So our mission for this deep dive is to explore that landscape. We want to pinpoint the key features, figure out how they're classified, and get a handle on how they're managed, all based on Dr. Kumar's insights from May 2019.
Exactly. It's quite complex.
You know, you might just think an ulcer is any old wound that isn't healing right, but the subtle differences in how they look, they can tell a really detailed story. Here's where it gets interesting. Let's get into the anatomy. An ulcer isn't just a hole, is it? It has distinct parts.
Absolutely, not just a hole. If we were to really look closely, we'd see several key components. First, there's the margin. That's the very outer boundary of the ulcer.
Okay, the boundary. And that could be smooth or jagged.
Yep, regular or irregular, and the overall shape might be rounded or more oval. Then connecting that margin down to the bottom of the ulcer is the edge.
The edge, got it. And the floor. That's what we actually see inside the ulcer. Dr. Kumar mentions things like discharge, granulation tissue, that sounds like healing tissue maybe, and slough. That doesn't sound good.
You're right. Granulation tissue is generally a sign of healing. It's new tissue forming. Slow, though. That's typically dead tissue the body's trying to clear away. It often looks yellowish or whitish.
Okay, and under the floor is the base, what it rests on.
Exactly. The base is what the ulcer sits on. Could be soft tissue, could be muscle, could even be bone in deeper ulcers. But, some of the most revealing clues about what's going on are found right at the edge.
Ah, the edge again. Tell me more about these different edge types. The material describes them in a way that makes you realize they're like diagnostic signs.
They really are significant clues. Take a sloping edge, for example. Dr. Kumar explains this often indicates an ulcer is actively healing.
Sloping inwards like a gentle ramp.
Kind of, yeah. You might even see distinct color zones within it. A red inner part, that's the healthy new granulation tissue, a whitish outer part, which is scar tissue starting to form, and sometimes a bluish middle zone where new skin cells, the epithelium, are migrating across.
So a sloping edge is generally a good sign then.
Generally, yes. It shows the body is making progress, closing the gap. But then you have something like an undermined edge.
Undermined, what does that look like?
Think of it like a little cave entrance. The skin or membrane at the very edge hangs over the ulcer bed slightly. It's not attached right at the border. Dr. Kumar notes this is characteristic of tuberculous ulcers.
Okay, so associated with TB, what else?
Then there's the punched out edge. Imagine using a hole punch on a piece of paper, that sharp, almost vertical, well-defined border. That's what this looks like.
Really distinct.
Very. You often see this in gummatous ulcers, which are related to late-stage syphilis, and also in trophic ulcers. It's often linked to problems with tiny blood vessels and darteritis, where inflammation narrows the arteries and restricts blood flow.
Wow, so the edge shape points to specific diseases or blood flow problems. What about a raised and beaded edge? It's described as pearly white.
Yeah, that pearly white description is key. This edge type is indicative of a rodent ulcer, which is actually a type of skin cancer, basal cell carcinoma, or BCC.
And the beads, what are they?
Those little beads are actually clusters of actively dividing cancer cells. It's a visual sign of the uncontrolled growth happening right there at the edge.
That's quite alarming. And the last one mentioned is the averted edge. Rolled out.
Verted or rolled out, yes. This is typically seen in carcinomatous ulcers, other types of cancerous ulcers. The malignant tissue is growing so actively that it essentially spills outwards, rolling over the normal skin edge. You can find diagrams illustrating these different types.
It's incredible how much diagnostic information is packed into just the edge of a sore. Now, the material also mentions induration. What's that?
Induration isn't something you see as much as feel. It's a palpable hardening of the tissue around the ulcer.
Palpable meaning you can feel it when you press on it.
Exactly. Dr. Kumar explains it's often noticeable in certain types of cancers, like well-differentiated squamous cell carcinoma. You might also feel it in ulcers that have been around for a long time and have developed significant underlying scar tissue or fibrosis.
So it's a firmness.
A distinct firmness, yes. And there's a specific type called brawny induration, which feels very firm, almost woody, and that's often a sign of an underlying abscess, a collection of pus.
Where would you typically feel this induration? Just at the edge?
You check for it at the edge, yes, but also at the base of the ulcer and in the tissue immediately surrounding it.
And why is that important?
Well, feeling how far that hardness extends is crucial, especially if cancer is suspected. It helps determine the true extent of the disease. Surgeons use the edge of the induration as a guide when they plan the surgical removal to make sure they get clear margins around the affected tissue.
That makes sense.
Yeah.
You need to get it all out. Okay, let's shift gears to how ulcers are classified clinically based on how they look and act. First up is a spreading ulcer. That sounds pretty active and not good.
No, spreading implies it's getting worse. According to Dr. Kumar, this type has an inflamed, irregular edge that's also edematous, meaning swollen. It usually develops quickly, so it's acute, and it's typically painful.
And the inside, the floor.
The floor won't have that healthy red granulation tissue we talked about. Instead, it's likely covered in purulent discharge pus and slough. The surrounding skin will also look red and swollen. It looks angry.
Yeah, it definitely sounds like an active infection. Okay, the opposite end of the spectrum then. A healing ulcer. This is what we want to see, right?
Absolutely.
Yeah.
A healing ulcer typically shows that sloping edge we discussed. The floor will have healthy granulation tissue, usually pink or red.
Less discharge too.
Yes, usually minimal discharge, and it would be Syrtes clear or slightly yellowish, watery fluid, and importantly, no slough. The nearby lymph nodes might be a little swollen but shouldn't be tender. And critically, no redness or hardness, no induration in the surrounding tissue or the base.
And Dr. Kumar mentions those color zones again.
Right. You might see the 3 zones. Innermost red, granulation, a middle bluish zone, new skin cells migrating, and an outer whitish zone, scar tissue forming. A clear picture of repair.
Okay, good. Then there are non-healing ulcers. This sounds like they're just stuck.
Essentially, yes. They aren't progressing towards healing. This is often a chronic situation. The edge can vary a lot depending on the underlying cause. It could be punched out, undermined, rolled out, maybe beaded.
And the floor.
The floor usually has unhealthy granulation tissue, maybe some slough. The discharge can be varied to serous sanguineous, clear fluid mixed with blood, purulent, or just frankly bloody. Lymph nodes might be enlarged, but often aren't tender. They're just not getting better.
Right. And the last clinical type is a callus or stationary ulcer. Callus sounds tough, resistant.
That's a good way to think of it. It's a type of chronic non-healing ulcer. The granulation tissue inside is typically pale, maybe flabby, whitish yellow, definitely looks unhealthy.
What about discharge?
It can be minimal, just a thin serous fluid, or sometimes, surprisingly, quite a bit of serous sanguineous discharge. But the key feature is the edge and base. They're indurated, so hard and thickened, but usually not tender, and they often feel fixed, like stuck down to the tissues underneath.
So just no progress.
Pretty much no tendency to heal. These can last for months, even years. There's often more tissue destruction happening than repair. You might also see hardness and maybe darker pigmentation in the skin around it. And lymph nodes nearby could be firm or hard, but again, often not tender. Dr. Kumar notes, callus here means insensitive, hard-skinned, resistant to healing.
Okay, those clinical types give a really good sense of the different states an ulcer can be in. Now, there's also a simpler classification based just on time.
Yes, that's straightforward. An acute ulcer has been present for less than 2 weeks. A chronic ulcer has persisted for more than 2 weeks.
Seems simple, but probably important for diagnosis.
It is. The duration gives clues about potential causes and affects the treatment approach. Chronic ulcers often have more complex underlying issues.
Right. Now, things get even more specific with the pathological classifications. This seems to be about the actual underlying cause. First, specific ulcers like tuberculous and syphilitic.
Exactly. These are caused by specific infectious agents. Tuberculous ulcers have features related to the TB bacteria, And syphilitic ulcers, or gummatous ulcers, often have that classic punched-out edge, a deep base, maybe that wash leather-looking slough inside, and an indurated base. Other specific ones mentioned are actinomycosis and Meline's ulcer, caused by particular microbes.
Okay. Then malignant ulcers. These are the cancerous ones.
Yes. Carcinomatous ulcers, rodent ulcers, BCC, and melanotic ulcers. These are essentially cancers presenting as ulcers, and as we discussed, their edges can sometimes give clues.
And finally, this huge category of nonspecific ulcers. This looks like it covers almost everything else.
It really does. It's a broad category. It includes traumatic ulcers caused by mechanical injury, like friction or a blow, physical injury like burns, or chemical injury, very common.
Makes sense.
Then you have arterial ulcers caused by poor artery blood flow from things like atherosclerosis or TAO, thromboangiitis obliterans.
And venous ulcers.
Those relate to vein problems, often in the legs due to gravity or issues after blood clots post-phlebitic syndrome. Then there are trophic ulcers, which are pressure sores. We'll definitely talk more about those. Infective ulcers from common bacteria like staph or strep. Tropical ulcers.
Vincent's ulcer.
Yes, often the callus type. Cryopathic ulcers from cold, like chilblains and frostbite. Martorell's ulcer linked to high blood pressure. Bazin's ulcer. Diabetic ulcers, a huge category in itself.
Wow, the list keeps going.
It does. Ulcers can even be linked to leukemia, polycythemia, jaundice, collagen diseases, lymphedema. And Dr. Kumar mentions cortisol ulcers, which can happen from long-term use of steroid creams. They tend to be callous, hard to heal, and might need surgery.
That list is incredible. It really drives home how many different paths can lead to an ulcer.
Absolutely. It shows that an ulcer isn't just a skin problem. It can be a sign of something systemic.
And related to that, there's Wagner's grading system. This sounds like it's used to assess severity, especially for diabetic foot ulcers.
Yes, exactly. Wagner's grading is widely used, particularly for diabetic foot ulcers, to standardize how we describe their depth and severity. It's crucial for planning treatment and monitoring progress.
So how does it work?
It goes from grade 0, which means there's no open ulcer, but maybe the skin is at risk or there's a healed ulcer, up to grade 5, which is extensive gangrene of the foot.
And the grades in between.
Grade 1 is a superficial ulcer, just involving the skin. Grade 2 goes deeper into subcutaneous tissue, maybe exposing tendon or joint capsule. Grade 3 is a deep ulcer with infection, like an abscess or osteomyelitis bone infection. Grade 4 involves localized gangrene, maybe of a toe or part of the forefoot.
Okay, so it's a scale of depth and tissue damage, plus infection and gangrene. Very useful clinically.
Very. It gives everyone a common language.
Now let's talk about discharge, what comes out of the ulcer. Maybe not the nicest topic, but the material says the appearance of the fluid is informative.
Definitely informative, yes. The type of discharge can give big clues. A serous discharge, clear, watery, maybe slightly yellow, is typical of a healing ulcer.
Okay, that's good. What about bad signs?
Purulent discharge, that's pus, a clear sign of infection. And Dr. Kumar even notes different bacteria can give different appearances. Staph infections often produce yellowish, creamy pus. Strep might be more bloody and opalescent. And Pseudomonas infection can famously cause a greenish discharge due to a pigment it makes.
Greenish, wow. What about blood?
Bloody discharge can be seen in malignant ulcers as they can bleed easily, but it can also happen in a healing ulcer if the delicate new granulation tissue gets bumped or disturbed.
So not always a bad sign on its own.
Not necessarily. You might also see mixes like seropurulent, serofluid and pus, or serosanguinous, serous fluid and blood. And there are some specific ones. A discharge with little sulfur granules points towards actinomycosis, and a generally yellowish discharge might suggest a tuberculous ulcer.
It's like the ulcer's communicating through its secretions. Now, we keep mentioning granulation tissue. Can you define that more clearly? Healthy versus unhealthy.
Sure. Granulation tissue is basically the body's repair material. And Dr. Kumar describes it as a mix of new, tiny blood vessels, capillaries, and fibroblasts, which are cells that make connective tissue, plus some blood cells, all covered by a thin layer of fibrin.
And healthy granulation tissue looks.
Healthy granulation tissue should look bright red or pink, maybe a bit bumpy or granular, which indicates a good blood supply and active healing, often described as beefy red.
Okay, and unhealthy.
Unhealthy granulation tissue might look pale, dusky, or grayish. It might bleed very easily or not bleed at all. It could be covered in slough or have that purulent discharge we talked about. The edges of the ulcer might be inflamed. In chronic, non-healing or callous ulcers, it often looks pale and flat, lacking that vibrant, bumpy appearance.
Right. And then there's exuberant granulation tissue. proud flesh. Sounds like too much of a good thing.
That's exactly what it is. It's when the granulation tissue grows excessively, protruding up above the level of the surrounding skin. Dr. Kumar notes it's often associated with irritation, maybe a foreign body in the wound, or infection.
And that's bad because...
It actually stops the healing process because the new skin cells, epithelium, can't migrate across that bumpy, raised surface. It creates a barrier. So this proud flesh often needs to be removed, maybe scraped away or chemically cauterized, before healing or skin grafting can proceed.
Okay, so careful visual assessment is key. But what about actual lab tests or imaging? What investigations might be done for an ulcer?
Well, several things might be needed. Studying the discharge is common, sending it for culture to identify bacteria and sensitivity testing to see which antibiotics will work. You might do an AFB study if TB is suspected. Cytology examines the cells for abnormalities, including cancer.
And biopsies.
Yes, a wedge biopsy is very important, especially if malignancy or a specific condition is suspected. A small piece of tissue is taken, usually from the edge of the ulcer where cells are actively multiplying. Taking it from the necrotic center might not give useful information. Sometimes multiple biopsies are taken.
What about imaging?
An X-ray of the area is often done to look for underlying bone involvement, like periostitis, inflammation of the bone surface, or osteomyelitis, bone infection. If lymph nodes nearby are enlarged, a fine needle aspiration cytology, FNAC, might be done to check the cells in the node.
Any other tests?
If a tuberculous ulcer is suspected, a chest X-ray and a MAN2 skin test are standard. And general blood tests are usually done checking hemoglobin for anemia, ESR or C-reactive protein for inflammation, white blood cell count for infection, and serum protein, especially albumin, as low protein levels can impair healing.
Yeah, it's a thorough workup.
Yeah.
So once you have a better idea of the cause and state of the ulcer, how is it managed? It's clearly more than just a bandage.
Oh, absolutely. The cornerstone of management is finding and treating the underlying cause. That's paramount. Alongside that, you need to correct any contributing factors, like anemia or nutritional deficiencies. Protein and vitamins are crucial for healing.
Right, support the body's ability to heal.
Exactly. Proper investigation guides this. Sometimes blood transfusions are needed. Controlling pain and infection is key. And then there's local care, providing rest, maybe immobilizing the area, elevating it if there's swelling, and protecting it from further trauma.
And the direct ulcer care. You mentioned debridement and cleaning.
Yes, local ulcer care involves several steps. Debridement is the removal of dead, damaged, or infected tissue, the slough and any necrotic material, because that stuff hinders healing. Cleaning removes debris and reduces bacteria. And applying the right dressing protects the wound and creates a good environment for healing.
How is debridement done?
It can be done mechanically, using instruments like scissors or scalpels. This might be a small procedure done in a clinic or a larger one needing anesthesia in an operating room. It can also be done chemically, using agents that help break down dead tissue. Dr. Kumar mentions hydrogen peroxide, acroflavine, and UCL Edinburgh University solution, which is a mild antiseptic and dislocating agent. He does note some controversy around using povidone iodine directly in open wounds.
You mentioned UCL. How is that used?
Sometimes as a bath for, say, a foot ulcer. A dilute solution is made, and the foot is soaked for 20-30 minutes. It helps clean the ulcer bed and remove slough. Hydrogen peroxide works by releasing oxygen, which can help lift off necrotic debris.
Okay. And cleaning?
For general cleaning, normal saline solution is usually considered ideal because it's isotonic and doesn't harm healthy tissue.
What about dressings? There seem to be many types.
Yes, modern wound care has a huge array of dressings. Simple films, hydrocolloids that form a gel, hydrogels that add moisture, hydroactives, foams that absorb exudate. The choice depends on the ulcer type, the amount of discharge, and the stage of healing.
You mentioned debridement methods. Are there others, like enzymes?
Yes, enzymatic debridement uses ointments containing enzymes like collagenase to break down specific components of dead tissue. There's also autolytic debridement, where the body's own enzymes are used under a moisture-retentive dressing. And hydrotherapy or certain dressings can provide mechanical, non-selective debridement.
Okay. And then there's VAC therapy, vacuum-assisted closure.
Right. VAC therapy is a very effective tool for many types of ulcers. It involves applying controlled negative pressure suction over the wound bed.
How does that help?
It does several things. It draws out excess fluid and reduces edema, which improves blood flow. It helps pull the wound edges together. It stimulates the proliferation of cells and the formation of healthy granulation tissue.
How's it set up?
Usually, a sterile foam dressing is cut to fit the wound, a drainage tube is placed over it, and the whole thing is sealed with an adhesive, transparent drape. The tube is connected to a pump that creates the negative pressure, maybe 25 to 200 mmHg. It might be continuous at first, then intermittent. Dressings are typically changed every few days.
Sounds quite advanced.
Yeah.
What about maggots? You mentioned that briefly. Is that really used?
It is. Maggot debridement therapy, or MDT, is a form of biotherapy. It's not super common, but it has its place. Specially bred, sterile larvae, usually of the green bottlefly Lucilia sericata, are applied to the wound.
And what do?
They selectively consume only the dead, necrotic tissue and bacteria, leaving healthy tissue unharmed. They secrete enzymes that liquefy the dead tissue, making it easier for them to ingest. They can reduce bacterial load, even MRSA. They might alter the wound pH favorably and stimulate granulation tissue.
Wow. That's something else. Nature's little surgeons.
In a way, yes. Once the wound is clean, thanks to the maggots or other debridement methods, it might be closed with sutures, a skin graft, or a tissue flap.
Okay, that covers general management. Now, the material revisits some specific ulcer types in more detail. Traumatic ulcers first, caused by injury.
Exactly. Mechanical trauma, like a scrape, impact, or even dental injury in the mouth. Physical trauma, like burns, electrical or thermal. Chemical trauma from acids or alkalis. They usually start acute, superficial, painful, and tender.
But they can become chronic.
Yes, especially if they get infected or if the blood supply is poor, they can deepen and become non-healing. Dr. Kumar mentions footballer's ulcer on the shin from repeated minor trauma, often getting infected with staph, becoming chronic and deep. Severe trauma can lead to necrosis, fasciitis, crush injury to vessels, resulting in large, deep, non-healing ulcers.
Treatment depends on the severity.
Yes, regular dressings, maybe antibiotics if infected. Larger or deeper ones might eventually need skin grafting once the bed is healthy.
Okay. Then trophic ulcers. These are pressure sores, bed sores, a big issue.
A very big issue, yes. Trophic ulcers, also called pressure sores, decubitus ulcers. They happen because of prolonged pressure, usually over a bony point that cuts off blood supply. If pressure is over about 30 mmHg for too long, tissue hypoxia occurs, leading to necrosis and ulceration.
Where do they typically occur?
Common sites are the sacrum, the ischial tuberosities, sitting bones, heels, elbows, shoulder blades, back of the head, anywhere a bone is close to the surface and bears weight or pressure.
What makes someone susceptible?
Lack of mobility is key, inability to shift position to relieve pressure. This is common in neurological conditions, after surgery, or in debilitated patients. Poor nutrition weakens the skin. Inadequate padding helps. And moisture, like from incontinence, can macerate the skin, making it fragile and prone to infection and breakdown.
So nerve damage can be a factor. You mentioned neurogenic ulcers.
Yes, impaired sensation means the person doesn't feel the discomfort that would normally make them move. So conditions like diabetic neuropathy, spinal cord injury, paraplegia, peripheral nerve damage, even leprosy or spina bifida increase the risk significantly. They are often called neuropathic or neurogenic ulcers in these contexts.
How do they typically develop?
They might start as a hardened area, a callosity, from repeated pressure. Then it breaks down, maybe suppurates, and can form a hole that penetrates deep, sometimes right down to the bone, a perforating ulcer.
What do they look like?
Clinically, they affect about 5% of hospitalized patients. They can be painless due to the nerve issues, often have that punched-out look. The base might be bone, and the ulcer feels fixed.
Investigations would include
Checking the discharge for infection, blood sugar for diabetes, maybe a biopsy if it looks unusual, and x-rays to see if the bone is involved.
And treatment is complex.
Very. Treat the cause if possible, like controlling diabetes. Nutritional support is vital. Absolute pressure relief is key, frequent repositioning, special mattresses or cushions, antibiotics for infection, surgical debridement to remove dead tissue, regular dressings. VAC therapy can be very helpful here, using intermittent negative pressure.
And if it's really deep.
Once a clean, granulating base is achieved, surgical closure might be needed, often using skin flaps, rotating or transposing nearby healthy tissue to cover the defect. Sometimes muscle flaps are used. Prevention, though, is the most important thing.
How do you prevent them?
Meticulous skincare, keeping skin clean and dry, regular inspection, especially over bony points, moisturizing, gentle massage to improve circulation. Frequent turning every 2 hours is standard for bedridden patients. Limb elevation, good nutrition, managing incontinence effectively. Patient and caregiver education is huge.
It sounds like constant vigilance is needed.
It really is.
Lastly, the document mentions ulcers from frostbite.
Yes, Cryopathic ulcers, caused by exposure to freezing temperatures, especially wet cold, maybe with wind chill. It causes blood vessels to spasm, damages cells directly, leads to tissue death, gangrene, and ulceration.
And these tend to be deep.
Yes, frostbite injury often goes deep, so the resulting ulcers are typically deep as well.
Well, this has truly been a comprehensive deep dive into what seemed like a simple topic. Ulcers are incredibly complex.
They really are. As we've seen, they come from so many different causes, and the way they look, the margin, the edge, the floor, the discharge, tells such a detailed story about the underlying process. The classifications help us make sense of it all.
And some details were genuinely surprising, like, the specific edge types pointing to specific conditions that beaded edge for rodent ulcer, or the different colors of pus, meaning different bacteria, and, well, the maggots.
Right. It really underscores how intricate our body's responses are and how much we can learn from careful observation. Even the use of something seemingly primitive like maggots has a sound scientific basis in the right context.
It definitely makes you think. Considering this complexity, how often might a minor skin issue, maybe a sore that just won't heal, actually be an early flag for something more significant going on internally? Makes you want to pay closer attention, doesn't it?
That's a really important thought to take away. Listen to your body. And while we covered a lot, this is still just scratching the surface. If specific types of ulcers or their management caught your interest, there's always more to learn and explore.